right, it's still good morning, Nigeria, live on the network service of the NTA. And to get into our conversation, let's quickly take a look at this background report put together by our correspondent Ibrahim Dan Hamidou.
In today's fast-paced world, taking care of our mental and physical well-being is more crucial than ever. A healthy heart is deeply connected to our emotional intelligence. Emotional intelligence is the foundation of a healthy heart. It is the ability to recognize, understand, and manage our emotions. According to the World Health Organization, emotional intelligence plays a vital role in our relationships, decision-making, and overall well-being. So, what triggers emotional imbalance? Capable of threatening the heart's well-being? Stress, anxiety, and past experiences are common culprits. Fortunately, mindfulness practices like meditation and deep breathing can calm the mind and body. To maintain emotional balance, cardiologists with the World Health Organization consider essential habits like these: regular exercise, journaling, nurturing social connections, and gratitude practices which reduce stress and improve sleep quality. They say a healthy heart also relies on a balanced lifestyle of a diet rich in whole grains, fruits, vegetables, lean proteins, and healthy fats. Regular cardio checkups, including blood pressure monitoring, cholesterol screenings, electrocardiograms, ECGs, and stress tests. By prioritizing heart health and emotional intelligence, people can master their emotions and live more fulfilling life. As the World Health Organization emphasizes, preventive care and self-awareness are key. Join the conversation as our guests discuss practical strategies for managing the heart, from emotional intelligence to heart-healthy habits.
Many thanks, Ibrahim, for that background report. Now, time to introduce our guests, and it's a pleasure to have with us right here for the conversation, Managing the Heart, Professor Augustine Orderly, President, Nigerian Cardiac Society. Many thanks for joining us, Prof.
Yeah, thank you very much.
All right, we also have with us, but joining us via Zoom, all the way from India, Dr. Iseko, consultant physician, international cardiologist, cardio care multi-specialty hospital, Abuja, and group medical director, the Limi Hospitals, Abuja, and also the chairman, Guild of Medical Directors. Many thanks for joining us, Doctor.
Thank you for having me. Good to be here.
All right, maybe we should start from India. Perhaps I should say namaste.
Namaste to you too.
So, when I go to the buka or some restaurant, I ask them to give me, do you have the heart, of the meat? Because I have this sense that it's something good for me. Not because it adds to my heart, though. So I say, give me the heart. But tell us, what's the so special about the heart?
Okay, so the heart, thank you for having me. I'm very glad to be here. The heart is, of course, like you know, the most important organ in the body, it seems. And it's one of the most mentioned organ in the entire Bible, the heart of man. Now, when it concerns to how the body works, essentially the heart plays a very critical role. It acts like a pumping machine that pumps blood around the entire body. One thing about the heart is that once the heart stops, within 4 or 5 minutes, the person is gone. And so this heart actually starts beating from within 4 weeks of conception till the final day when we say goodbye to this earth. So keeping that heart in good working condition and all the vessels and the pipes that are connected to this wonderful pumping machine is critical. So the heart has 2 ways it works, 2 components in that regard. One is an electrical component that keeps it pumping, and the other is a pumping component or a piping component that makes sure that all the pipes that supply itself and that its supplies are working well and at the right pressures. So those are the things that play a role in heart health. And heart health is critical for every Nigerian. Around the world, we know that heart disease is perhaps the leading cause of death around the world, and Nigeria is no exception. And it's beginning to play a very important role. We've seen recent evidences, recent people dying even on TV, even in National Assembly, and it's something that all of us need to take full cognizance of, especially here in Nigeria.
When you hear, and we do hear this often, you say someone has a heart attack. What does it mean?
All right. So a heart attack simply means that the pipes supplying the heart itself are blocked, meaning the heart itself, the pumping machine of the body, is not getting enough blood supplying it, and therefore it cannot pump as well. So a heart attack, typically patients have chest pain, they have sweating, difficulty in breathing, and could suddenly drop or lose consciousness. That is a heart attack. Now, we must differentiate a heart attack from a cardiac arrest. A cardiac arrest means the heart has stopped beating. So it's like an electrical problem. While a heart attack is like a plumbing problem. The pipes supplying the heart itself are blocked, and therefore that part of it that is supposed to have gotten supply does not get supply. If it doesn't get supply, that part of the heart muscle dies, and that can lead to a whole lot of problems, including a cardiac arrest, which is stopping of the heart completely. The third thing we differentiate a heart attack from is heart failure. When the heart is not working as well as it ought to be, it's not pumping well or relaxing well. So that is heart failure. While heart attack simply means that the pipes supplying the heart itself have been blocked, and therefore that heart is not getting enough blood and not working as well.
All right. Many thanks, Dr. Iseko, for laying the background for our conversation. But I'd like to take advantage of this very clear Zoom connection, quickly, before we get to Professor Augustine, who is right here with us in the studio. I hope you understand, because, Zoom connections can be a bit tricky. So I'd like to stay with you, Dr. Iseko. You have told us what heart failure, what heart attack is, and of course, that the heart is a pumping machine. Beautiful. But tell us, what could make this pumping machine become faulty? You say it starts to beat from 4 weeks after conception till death. But we do know that some people live with certain heart conditions. What could be responsible for it, considering the fact that, it's not something we can touch. We do not. Can we control how it works?
All right, so thank you very much for such an interesting question. Now, the etiology of what causes heart problems in Nigerians is quite multiple, but one of the most important causes essentially is when the pumping machine, as it were, the heart, is pumping into pipes that have a very high pressure, which is hypertension. So when the blood pressure or the pressure of the entire body is high, that pumping machine has to pump against a very high pressure. That now sends a negative signal back to that heart and around to the entire body. So that's one of the most common causes of heart disease in Nigeria. Before we have other causes where certain valves inside the pumping machine could have a problem or the other. So first of all is hypertension. Unfortunately, most of these symptoms are not very obvious to the individual, and so the most important thing we tell people is to check. Most of our studies done in Nigeria show that 1 in 3 people do have some level of high blood pressure. WHO estimates that 1 in 5 people will have diabetes, and then that is complicated by strokes, by high smoking, by high stress lifestyles. All those things are complicated. Unfortunately, if we wait for the symptoms, it could get quite late. The typical symptoms are just feeling chest pain, feeling unnecessarily tired, unable to walk, leg swelling, which some of our people say they match poison. But all of those things indicate that the heart is not working well. And unfortunately, the most important thing is for us to get to the hospital and get appropriate treatment. Besides taking care of our diets, taking our blood pressure medications and any pills that the doctors have recommended for us. So it's critical. It's critical for us to do all these right things. But most importantly, if you are feeling fine today, get to the hospital at least once a year and get a good checkup.
All right. Thank you very much, Doc, let me get here in the studio where we have Professor Augustine. He's talked a bit about, the dangers to the heart. He's talked about what we should do when there are issues. But what should we do so that there will be no issues, that we don't have to get to the hospital at all? What's the place of diet in all of these, for instance?
Okay, thank you very much. I thank Dr. Iseko, who is also a very active member of the Nigerian Cardiac Society. When you were introducing him, you said he's talking from India, as if he's in India. He's not in India, he's in Nigeria. It's just that he went to India for some conference.
Yeah, but at the moment, he is in India.
At the moment, yes, I just needed to make, so it's not it's not that he has jabbered.
We know his hospital.
Okay, so
President, you are trying to make sure that he comes back.
Yes, I want to make it clear that that is one of the things we are pushing for, that members of Nigerian Cardiac Society who are here will continue to do the work here. So I just
President, you get a second term.
Okay. Well, I'm already in the second term.
It means we need to elongate your tenure.
So thank you very much for that. The points are very clear. What we are pushing for, I like the way you put it, is that people do not even need to get to the hospital, really. That's health promotion. Because if you do health promotion, then you don't need to get to the hospital. And it is cheaper to do, easier to do for everybody. So what are those health promotion things that we need to do? One, we need to check our blood pressure regularly. I mean, when he was talking, he mentioned the burden, the number of people in Nigeria who are hypertensive. We carried out this study. I led a team that moved around the whole country. When I talk, I want to mention the places where we went to, so that all Nigerians will relate with the figures we are giving. And I want to mention it again here. We started the 6 geopolitical zones of this country. We took one state each from each of the 6 geopolitical zones, and each of those states, we went to an urban community and a rural community. I'm going to mention the names of those communities all around the country, so that all Nigerians will relate with the figures we are reeling out. Now, for southeast Nigeria, we went to a rural community called Okuzu in Oyi local government area of Anambra State. And the urban community was Onitsha. If you know Onitsha, around the Omaba area, that was where we took our urban sample for southeast. Now we went to south-south. We were in Uyo town for south-south, and then we went to a community called Ekota Akbamba in Uyo. Then for southwest, we were in Ibadan town, and then we went to a community called Igbo Eleyin. For north central, we were in Lugbe here in Abuja, Federal Housing Authority, Lugbe here in Abuja. And then for the rural community was at Dobi. If you go from the teaching hospital, Gwagwalada, if you drive about 20, 30 kilometers, you get to that community. Then for northeast, we went to Gombe town. And then for the rural community, we went to Tula in Gombe. Now one is left. Now for northwest, we went to Guso town. And for the rural community, we went to Nahuche. So I have given you all these places. So you will be interested in, what did you find? We found out that 38% of adult Nigerians, in that study, we measured people's blood pressure. We didn't allow them to come to the hospital. We moved around with, a vehicle, around this country. The study I'm talking about was funded by TED Fund, the National Research Grant of TED Fund, which I got in 2017. I was the principal investigator. Why I'm giving these figures is so that Nigerians will relate directly with what we are talking about. TED Fund funded this research project, and we went around these places. So what did we find? I'm sure that would be your interest.
Yes.
We found out that 38% of adult Nigerians are hypertensive. Now, the implication is that it's about 4 out of every 10. That's what 38% means. That if you gather 10 people, 4 of them will be hypertensive. And of this number, about 60% of them are aware that they are hypertensive. You see, the challenge with hypertension is that you will be hypertensive because it doesn't give any symptom. You wouldn't know that you are hypertensive. So you move around your usual business. In fact, those few people have some symptoms when they are hypertensive. Those people are what I call the exception. The usual presentation is that you wouldn't know. And that is why we call it a silent killer. Does that make some sense to you now? So people wouldn't know. Now, out of the people who know that they are hypertensive, only 30% of them are receiving treatment. Now, out of those who are receiving treatment, only 10 to 20% of them have their blood pressure under control. So I think you can now relate with these statistics. Are you getting it? And like Dr. Seko rightly pointed out, what hypertension does is that it affects those pipes, he calls them the pipes, that lead blood out of the heart. It affects them so much so that the heart muscle begins to get thickened as a way of, responding to the fact that the heart will be pumping against a very high and elevated pressure. So the heart muscles will begin to thicken up. Now, it continues to do that until it gets to a point that it becomes too weak. It can no longer, adapt to it. And at that point, we say it has failed. But it may not fail for everybody. As it is getting thicker, it means that the blood that supplies oxygen to it will not be enough because it's now thicker than what it's supposed to be ordinarily. And then again, there may be a deposition of cholesterol on the wall. Other things like cigarette smoking may also affect that pipe, will make that pipe not to be as smooth as it's supposed to be, Then what will then happen is that there will be a blockade of that artery, the pipe that supplies the heart. And that is what can give to heart attack, like he said. So you see why we always talk about hypertension. Now, other things like physical activity, people need to exercise, and so that you don't live a sedentary life. So we are talking about health promotion. So the important thing really is that if we are able to control blood pressure, we are able to control obesity, people bigger than normal, we are able to increase our physical activities, we reduce smoking, and then we are, you find out that, many of these diseases that require a lot of funds for its treatment, I'm sure we are going to get to that, would not happen. So health promotion is key. And it is so important in Nigeria. I'm going to tell you one thing we did in Nigerian Cardiac Society. We call it Know Your Numbers. Now, Know Your Numbers was what we launched last year. And the essence of Know Your Numbers is that people needn't go to hospital to find out their blood pressure. Blood pressure, hypertension is the easiest thing you can diagnose in this world. You can make the diagnosis here. You can make, drivers can make diagnosis, security men.
How?
You train them on how to measure blood pressure.
Is the equipment not expensive?
It's not. In fact, what we are doing now, we got a support to make sure that, we put this thing in not what I call non-clinical areas. For example, shopping malls, and all that. That is what we can do to train people on how to measure their blood pressure, both at home, in shopping malls, at the airport, everywhere. And that is our vision in Nigerian Cardiac Society.
All right, Prof. I'm going to ask you a question about how effective these machines are and if some are more effective than others. Because, based on experience, sometimes you go to a hospital, you want to get a tested, you want to check your blood pressure, they use a particular equipment is reading very high, and then they bring another one is reading very low. They bring another one. I mean, so all of that you would want to, respond to that, because I think that I've had that experience, in the past. But let's look away from that. Let's go to Kano now. We have Professor Hadiza Seidu, consultant cardiologist, Northwest coordinator, Nigerian Cardiac Society, joining us for the conversation. Prof, I'm excited that you're here. I'm sure you've been following the conversation. Professor Iseko and Dr. Iseko and Professor Odili have spoken so much about, the heart and what could result in heart complications. But you see, I'm worried, because we know babies are born with heart issues. They don't have hypertension in the womb. They don't have to do anything. They don't smoke and all of that. But they have heart issues. Why is that, and what's responsible for heart conditions for babies or children rather?
As has been discussed by colleagues previously, hypertension appears to be the most important culprit in the development of cardiovascular diseases. And then, of course, when talking about hypertension, we have classifications. In over 80% of individuals, we call it essential hypertension, because there is no known cause attributed to that. However, there are factors that are associated and predispose these individuals to developing hypertension. That is 80–85% of these individuals, which have some family history. So hereditary is important, and those individuals, males or females, with a family history of hypertension are prone to developing hypertension in the future, and the risk for the development of this high blood pressure increases when both parents are hypertensive. Then secondly, there are lifestyle issues such as high salt intake. Individuals with a high level of salt intake are also prone to developing hypertension than individuals with a lower intake of salt. Also, individuals with a good diet. So diet plays a significant role in the subsequent development of hypertension, whether in the males or in the females. A healthy diet, that is a diet that is rich in fresh fruits, fresh vegetables, low in salt, low in saturated or the solid fat, rich in omega diet, fatty omegas, are protective. In other words, high salt, high fat intake, diet that is poor in fresh fruit and vegetables also increases the risk to developing hypertension. Also, a sedentary lifestyle. Individuals with a higher physical activity tends to be more protected than individuals that are sedentary. Also, obesity. Individuals on the obese side are also prone to developing hypertension than individuals that are not overweight or obese. Similarly, habits like smoking tends to also predispose individuals to developing hypertension, and there's those that are also prone to alcoholic intake. Those with high level intake of alcohol are also prone to developing hypertension and heart diseases than those that take moderate alcohol or those that abstain from alcohol intake. Also, individuals with what we call have hyperlipidemia or dyslipidemia, which is nothing but abnormal cholesterol in the blood or abnormal components of lipids in the blood, are also prone to developing high level of blood pressure than those without dyslipidemia. Likewise, individuals with diabetes. Individuals with diabetes also have higher risks for developing high blood pressure than those without diabetes. This is for the essential hypertension, in which the majority of individuals fall within without any known cause. In the rest of the individuals, 5 to 15% of them, we have a cause that is attributed to the development of this high blood pressure, and this includes some form of drugs like oral contraceptive agents, some agents with use for the treatment of malignancies, like cyclosporine, some agents that we use in improving blood, like erythropoietin, steroids. So there are drugs that are also attributed to developing hypertension in individuals, which when withdrawn, the hypertension can be completely treated. And also individuals with a renal disease, that is kidney disease. Individuals with a kidney disease are also prone to developing high blood pressure, and there are certain forms of kidney diseases, which when treated, the high blood pressure will be treated automatically. There are also conditions that we call endocrine diseases that also poses risk to an individual to developing high blood pressure. Again, when we talk about women, we have a category of hypertension that we call pregnancy-induced, that occurs only in pregnant women when their pregnancy reaches from 20 weeks of gestation till birth. In these individuals, we are lucky for a percentage of them after birth, that blood pressure goes down and returns to normal because it's attributable to the numerous changes that occur in the body during pregnancy and childbirth. Then also, particularly in the northern part of the country, apart from hypertension, when we talk of women, we have a particular form of heart disease that occurs only in women of childbearing age. And this form of heart disease occurs from the from the 5th month of pregnancy up to the first 5 months after childbirth. This we call peripartum cardiomyopathy. And in some of these individuals also, we found out that this particular pregnancy-induced hypertension that I talked about is also part of the culprits in developing of this form of heart disease. It's very important I talk about it because in the world and in the north, and particularly in Kano, we found the highest incidence of this form of heart disease in our environment. It's actually too worrisome that we had to find a clinic particularly related to this particular of heart condition affecting women of childbearing age. Interestingly, we in Kano found that in every about 96 births that occur, one woman will develop this kind of heart disease. So it's quite significant and it's worrisome. And we are doing a lot to find out what might have caused this. Individuals we find with this kind of heart disease, these women, they typically present with breathlessness, that is shortness of breath, fatigue, body swelling during their few last months of pregnancy, and then up to the first 5 months after they had delivered. We found out that these women tend to be either the first timers of giving childbirth, what we call primary gravida, or those that had given multiple births, more than 5. We also found it to be common in individuals that are of younger age. Women less than 20 years in this part of the country get married and give birth, and we find a lot of them being culprits. And then we find also the elderly primaries, that is women we find with more than 5 childbirths, and usually with multiple pregnancy as culprits. Interestingly, and again, we know that once early marriage occurs, we know that education has been compromised. And so we find that these particular women tend to be of lower level of education, lower level of socioeconomic status, with a very poor diet. So these are very important. But then we find it interesting that it's not only Kano, it's not only the north that have poor women, or rather women of lower socioeconomic class, but then why is it happening just in Kano and in the north? We are digging into it. We are making a lot of collaborative researches.
All right, many thanks, Professor Seidu. for your opening comments on all that we need to know as regards, health complications as regards the heart, and talking specifically about women too. Very, very educative. But you didn't quite hit the nail on the head concerning my question about babies that are born with heart conditions. We have with us now, joining us for the conversation, Dr. Oladipo Ofason, Senior Consultant Cardiologist, Head Cardiology Unit, National Hospital, Abuja. He's also the Secretary General, Nigerian Hypertension Society. Many thanks for joining us, Doctor. All right, so I think I'll just hit you with the first question. By the way, I just think that, or rather from my observation, all the cardiologists are looking alike. It looks like, I don't know. Anyways, but let's get to you, Dr. Fason.
Yes.
I want you to tell me, the background has been laid already by all the doctors with us, talking about what can, cause a problem with your heart, your lifestyle, drinking, smoking, and all of that. But specifically, I want you to talk about babies. I know that children are born and they are born with heart conditions. What could be responsible for that? They don't have hypertension, they don't smoke in the womb. So what could be responsible?
Okay, thanks again for having me. It looks like today is strictly about the heart.
Yes.
And this is a fantastic thing. This is what we've advocated at the Nigerian Cardiac Society, at the Nigerian Hypertension Society, that we need established outfits like NTA to actually help drive home this problem of cardiovascular disease, which is rapidly rising in Nigeria. So that said, just to simply, I try to make it as simple as possible. So when newborns have heart problems, most times actually it's congenital. And when it's congenital, it's either of two ways. It could be congenitally inherited or congenitally acquired.
When you say congenital, for the benefit of our viewers,
Yes.
what do you mean?
Means they are born with it. Okay. But being born with something does not always mean it's genetic. It could also be acquired. So I'll give you an example. So, someone who has Down syndrome, a child that is born with Down syndrome, I'm sure we see some of them around. Mm-hmm. They often will have holes in the heart, some form of hole or the other in the heart. Mm. Down syndrome is a chromosomal abnormality, it's a genetic problem that has to do with the way the X and the Y chromosome, the sex chromosome, cross when the child, in utero, when fertilization takes place and the baby starts to develop. It's seen in women, commonly attributed to women who have kids at older age. Mm. Now, that is one. That is a genetically inherited or chromosomal abnormality which is inherited, and the child is born like that. But a child might not have any genetic problem. It could just be an ordinary infection of the mother in pregnancy or prior to pregnancy, which the mother didn't know and had not treated. For instance, back in the day, we have a condition called rubella. If a mother had some form of rubella or like that, the baby can come out with a congenital abnormality. So simply it could be acquired. Even alcohol, if a mother drinks during pregnancy, the child can come out deformed and a heart problem can be there. So I've just mentioned a few. There are so many others, sometimes even drugs that you use in pregnancy. Take for instance, there are certain drugs which we use to treat hypertension. We cannot give it to pregnant women. If you give it, that child is going to come out with some form of congenital abnormality. Most of the time, in this case, however, it will be kidney problem and other issues, not necessarily heart problem. But there are other drugs that have been shown to also affect the heart. Because what happens is that, especially in the first 3 months, if anything happens to that baby's development, which is when every organ is formed, the inducting process that leads to every organ being formed in the first 3 months of pregnancy, anything that disrupts that process will lead to a congenital problem. And a heart problem is one of the things that can come out of it. So, to summarize it, heart problems in children as they are being born, we call it congenital, could be due to either genetic or chromosomal problem, or it could be acquired, which could be from infection, from toxic substances, drugs, alcohol, and other things that can damage the heart.
All right. Thank you very much, Dr. Fason. But I would like to stay with you at the moment. We've talked about children born with heart defects. By the way, when you hear that a child has a hole in the heart, is that also hereditary?
Okay, so I've just said that being born with a hole in the heart could be either of two ways. Whether it's genetic, chromosomal, or acquired, maybe an infection, toxin,
Okay.
you know. Now, for it to be hereditary, it will fall into the genetic part. So there are certain genes that can be transferred to the baby from the offspring, from the parents to the offsprings. Such genes, some of them can predispose to heart problems. Sometimes it's not even a hole in the heart. I'll give you an example. There are genes now that we know. There's a condition called hypertrophic cardiomyopathy. Simply, it means the heart wall just goes crazy and gets thicker and thicker and thicker as people get a bit older and older. We now know that it's an autosomal dominant condition, meaning if a parent has it, the child is going to have it. Because usually there is a gene, some genes from the mother, genes from the father. Those are the things that make us up. When X and the Y chromosome, the egg of the mother and the sperm of the father meet, and in utero, the Y chromosomes carry the male from the father. The X are carrying from the mother. There is a mixture, and at the end of the day, we come out the way we come out. Whether you look like your father or like your mother is dependent on the dominant ones in that process. So one of these conditions is what we call hypertrophic cardiomyopathy. If anybody inherits it, it's always a dominant one. And that child, as the child starts to grow, the heart will just be thickening and thickening and thickening. And in a few cases, it's one of the causes of sudden death. You just see someone who goes to the football pitch to play football, dies there.
All right. Thank you very much, Dr. Fason, for that explanation. I'd like to get to Professor Odili now. We've talked about high blood pressure as being, a major trigger for heart complications. What does heartbreak have to do with heart complications?
Sorry,
Heartbreak, this emotional.
Okay.
Yes. Does it affect? Because when people say, I don't know, maybe you can explain.
You've inflicted a lot.
I just want to know that, I just want to know whether emotional stress, can also affect how the heart functions.
Okay, thank you very much. Maybe before I talk about that, I will help both Dr. Fason and Professor Saidu, who talked because of the children. And again, I would talk about data from Nigeria, because I want Nigerians to relate to these things. We are just coming back from Port Harcourt. We have our annual general conference barely 2 weeks ago. And one of the things that came out clearly there, it's about heart diseases in children. In fact, Professor Taibwe is a consultant pediatric cardiologist at University of Port Harcourt Teaching Hospital. I'm going to give you some data. Now, the presentation was that all over the country, they've checked these heart diseases in children. What people generally call hole in the heart. And discovered that it's about 16 per 1,000 births. But in Port Harcourt area, they reported about 81 per 1,000 births. This was just what we discussed barely 2 weeks ago. And all of us were all wondering, what could be responsible for this? We don't know. However, there is a point that we have not mentioned in all these discussions. Air pollution is also a contributory factor to heart diseases, both in adults and in children. Air pollution, when we are breathing bad air, and incidentally, this air is available to everybody. even if you have all the funds to have the best treatment anywhere in the world, but you breathe the air that everybody breathes. So we are all in it together. So I need to talk about it in this place. You were asking a child who is born yet had heart disease. He doesn't have hypertension because we have emphasized so much on hypertension. And my colleague has given you some of the things happening in the mother that can predispose to these heart diseases in the child. And I'm adding air pollution. Because the mother, if the mother is living in a polluted area, that will predispose the unborn child to, some of these things. And cigarette smoking in the mother, he mentioned all the others. Now there is another important disease. In as much as it appears as if it's going down in Nigeria, but we still see a lot of cases. Rheumatic heart disease. So let's not just concentrate on hypertension. Rheumatic heart disease is also another important thing. It starts with what we call rheumatic fever. A child will have fever, joint pains,
Sore throat.
and sore throat. The immediate reaction is that this is malaria. The child is treated for malaria. That fever may go down. Then after some time, when the child gets to about 15 years, that same thing that causes that sore throat has a way the body reacts and affects the valve. So this child may develop heart disease at the age of 16. So we also need to include that in the equation. So I think it's important that you pointed this out. I thank Professor Saidu for bringing out the aspect of heart diseases in pregnant women, which is in Nigeria is the where you have the highest incidence in the whole world.
With Haiti.
And our people, our colleagues in Kanu, that's why Professor Saidu was really quite passionate about it, because our colleagues in Kanu are leading the effort, that research. Now I will come down to heartbreak causing heart attack. Yes, stress as it is, because that heartbreak is an emotional stress, actually cause release of some hormones. And those hormones are we call them cortisol. One has effect on blood pressure and also has effect on the heart itself. In fact, there is a disease you call Takayasu cardiomyopathy. It's very common. We've not reported so many cases in Nigeria. It's very common in Eastern, like in Japan and all that. And one of the predisposing factors is very common in women when they have very terrible, emotional stress. Then they come down with that type of heart disease. But by and large, when we are exposed to very terrible emotional stress, it affects our blood pressure, it increases cortisol level in the body, and all these things has effect on metabolism. And anything that has effect on body metabolism also has effect on the heart. So I think this is the way I would want to
Thank you, Prof. So much has
we
been
actually
said.
call it broken heart syndrome.
Broken heart
Yes.
syndrome.
Yes.
Fantastic. Wow.
Takotsubo syndrome.
Yes.
So, Victor, take notes, just so that...
Well, I think I'm learning that you have inflicted a lot, and so you are very particular about this one. But what of hormonal imbalances? How does it affect heart health?
Okay, what kind of hormonal imbalances?
I mean, during menopause, for instance, in women.
Okay. Thank you for the question. Actually, hormones, the estrogen, has some protective effect. A protective effect on the heart. So initially, the thinking was that women are not so predisposed to heart disease because of the protective effect of estrogen. Yes, there are some, reported cases like that. When, in fact, this was actually my initial research, where I concentrated my research effort, looking at, hormones as it affects cardiovascular system. In fact, our colleagues in Jos, Professor Kahalam and the team in Jos, has that as their main research focus. We, of course, I trained in Jos anyway, so that's how I got to have this idea. But then during menopause, the level of estrogen drops. So you discover that the balance, that protective effect that women, the advantage that women have, they lose it. So during menopause, the woman becomes a man. Let me use it that way, as far as heart diseases are concerned. But I must sound a note of warning that even that protective effect, a woman who is diabetic loses that protective effect. In fact, it even becomes more. And then a woman who smokes. So these two things, for example, if a man smokes and a woman smokes, the deleterious effect of smoking on the heart of a woman is worse than smoking to a man. Smoking to everybody, it's not good at all. I mean, anybody who is smoking should stop. But if the minor advantage a woman has, at the time premenopausal, is lost if the woman is smoking. Diabetes and smoking, these two, affects that advantage. I think that's the way I want to summarize it.
All right, thank you so much. I'd like to get to Professor Hadiza Seidu now in Kano. Just to hear from her what she thinks, how managing heart defects is, considering the fact that you have a lot of cases in Kano, and you have talked about pregnant women, also having, a lot of complications. Tell us, how affordable is it in managing these heart conditions, and what is available in the country in terms of dealing with heart diseases?
Again, with the previous question, there was some break in communication, but I think it was important I brought out something that is quite obvious, which actually might not have been discussed. By and large, with regards to managing heart defects or heart conditions in the country, or one may pin down to Kano, it actually depends on the particular of heart defect or heart disease. We know heart diseases can be those affecting children or those affecting adults. With regards to children and the defects we talked about affecting children, they are mainly congenital and causes had been elaborated. We see that in these children, majority of them will require intervention in terms of surgery, which facilities are not available in Kano. We are yet to have a cardiac center in Kano, and even in the country, it is of recent, with the effort of the Nigerian Cardiac Society and other collaborators and foundations abroad, that we are able to make cardiac surgeries more affordable and more available. Majority of these patients are poor and cannot afford the cost of the surgery, which per surgery is nothing less than $6,000, which if we convert to Naira, is quite huge. So a lot of these patients will tend to rely on support from the government or support coming from foundations that the cost of the surgeries are being subsidized. Recently in Kano, the Cardiovascular Foundation came in and we intervened on this time around adult cases that require intervention. So most of these children will have to travel out of Kano, and in the northern part of the country, only available in Abuja, we have centers now that are coming up, which are mainly private centers that can offer these interventions, but of course the cost is there. So a lot of the children are not able to afford these surgeries, and some survive to adulthood, and we still see them in our adult cardiology clinics, by which time they have come with complications of what we call heart failure, and the heart function has been compromised. So affordability is key. Patients cannot afford, and availability is also key. But a lot of efforts are being made to see that we have wide coverage across all political zones, that patients can travel across with ease and have these interventions becoming affordable and accessible to them. When we come to the adult age group now, a lot of them also require some form of intervention in form of surgery. We've talked a lot about ischemic heart disease, talking about blockage to the cardiac supply, blockage to the artery supply in the heart, which lead to cardiac heart attack. For the patient that survive these events, they invariably require intervention in form of surgery, which also is a challenge. There is no single center in Kano that offers such intervention to open up these blocked arteries and prevent further catastrophe occurring to the heart. Again, centers are available in Abuja now and in the south and southeastern part of the country. Again, cost remains a very big challenge, and a lot of our patients here cannot afford this intervention, and at the end of the day, come with the end stage of heart disease, which is heart failure with recurrent attacks, and succumb to the disease. Not only surgical intervention, we also have adults that have these congenital heart diseases that have not had the opportunity of having intervention during childhood. A few of them afford that, and they get these interventions in conjunction with the foundations and the collaborative efforts, which the Nigerian Cardiac Society is central to these programs that alleviate our problems. And now patients don't have to travel abroad all the time to access these interventions. So they are brought to us here, they meet us at our facilities, and we're able to make arrangements, and patients have these interventions at a subsidized rate. When we talk of hypertension, which is central in cardiovascular disease, medical management, lifestyle is very important. And as Prof. Odili said, our president, a lot of these things can be managed effectively with health promotion and simple lifestyle measures. So once we buckle up, we do interventions, we educate our people on how to identify these culprits that are preventable, then we've achieved a lot. Lifestyle in terms of education on the healthy diet, on physical activity, exercises, regular monitoring of hypertension, regular monitoring of other comorbidities that affect the heart, like diabetes. Simple diabetes control can save the heart a lot. Cholesterol management. When we reach to getting to drugs, we know that getting a qualitative drug is a challenge in the country. There are a lot of drugs that are not so, that are fake, and this is part of the reason why we don't even achieve control. Number one, there's a lot of ignorance. Hypertension and heart diseases at the initial instance are silent. They don't present with any symptom. So unless there is health education and promotion, patients or individuals are taught on regular monitoring of the BP and other risk conditions like diabetes and cholesterol, patients wouldn't have known. And we see quite a number of them, up to 30% or more, coming for the first time with complication that the heart had failed, or other complications that are attributed to the blood pressure or the diabetes, which can simply be controlled or minimized with simple lifestyle. So cost of medications is not easy. Even with the cheapest affordable drugs, we see that a monthly pay or a monthly amount of not less than 20,000 will be required for the basic simple antihypertensive medications, the simple basic ones.
All right, thank you very much. Thank you, Dr. Seidu. At least one thing I've picked out from all that you have said is that it is expensive managing the heart, and then the facilities are not available. But let me quickly get to Dr. Iseko, who joins us via Zoom from India. I just want to find out, what are the latest technologies in managing the heart as we speak, and then how can government come in, how can individuals, the private sector come in to help drive down the cost of managing the heart?
Thank you very much. Yes, indeed. Heart condition is quite prevalent. Over the last 8 months, I can say that we've done about patients that have acute heart attacks ongoing. We've had to use advanced technology to open up those blockages with what we call stents through just a needle in the arm or in the leg. And so through that needle, we're able to perform complex heart surgery in less than 30 minutes to an hour and able to open up that blood vessel. So those technologies are available in Nigeria, but they are quite costly, as you know. One of the things that these technologies are available is called a cardiac cath lab. It's currently available in quite a number of centers, but particularly in the north, it's available in Abuja. It's also available in the southwest and in the south-south. Now, besides putting stents to open up blocked vessels, we also in Nigeria are able to put in devices like pacemakers, like cardiac resynchronization therapy devices, things that can stop sudden cardiac death. So we put it right under the skin, and we're able to monitor the heart rhythm through that computerized device. And that device is also able to treat when it finds a problem with the person that is being that is in that situation. So it's very important that it's available. Now, what can government do to help its citizens? We've been at the forefront of reaching out a Nigerian Cardiac Society and the Guild of Medical Directors, reaching out to the insurance agencies, the National Health Insurance Authority, and we've tried to discuss ways where innovative financing can bring the public and the private sector. Thankfully, the government has passed the new NHIA Act, which should make insurance mandatory, and that should make funds available for everybody. All over the world, nobody needs to bring out so many millions when they're having a heart attack. You can go in and have your insurance cover it. Unfortunately, right now in Nigeria, very few insurance systems are able to pay for such heavy services when you need an emergency, and that is the real reason for insurance.
All right. Thank you very much, Dr. Iseko. We'll come back to you because I'm sure you haven't quite completed. You've not landed on your points here, but we've got to take this break so that when we return, the conversation can continue. Please stay with us.
Welcome back. It's still Good Morning Nigeria, live on the network service of the NTA. And our topic of discussion this morning is the heart, managing the heart. And we still have our cardiologist still very much with us this morning. Before we went on that break, we were with Dr. Iseko, who speaks to us via Zoom all the way from India. I'll let you round off on your thoughts, Dr. Iseko, but I would like to add a question, to the one you were answering before we went on the break, and that will be, from all that has been said, managing heart conditions, medically is out of reach, for most Nigerians, and facilities are not even available. Anyways, but so much has also been said about healthy diets. When it concerns heart health, what really is a healthy diet?
Okay, thank you very much. So I'll start with the diet question. Diet is quite very important, and it helps to alleviate a lot of the conditions. So number one, as concerns Black Africans and Nigerians, we know that handling of salt by most Nigerians, those Black people, is not the very best. And that extra salt stays in the body and raises the blood pressure. So we want to cut down salt contents of our food. We want to cut down oily contents of our food. We want to also cut down carbohydrates, especially if your body has a difficulty handling sugar and what is called diabetes. All of these play a very big role in heart health and in keeping your blood pressure well controlled, and also keeping your cholesterol under control. Reduce red meat, to reduce oily foods. We want to have more leafy diets in our meals to make sure that we are having a very, very good meal and comprehensive diet. Now, what do we want to do? We want to make sure that our meal is balanced in such a way that we have a component of each part of the food: proteins balanced, vegetables balanced, fruits balanced in each of these meals. And that can go a very long way. Now, if we are unable to do that, then we have to manage the complications that come with heart problems. And this includes us knowing when to recognize such a heart condition, number one. Number two, knowing the facilities that are available that are right here in Nigeria that can take care of it. And number three, for making sure that there's a healthcare financing mechanism us when we get sick so that our heart can be taken care of. What does it include? It includes medications. It includes access to fast delivery the country. It includes access to facilities have advanced care of the heart, including putting stents, putting pacemakers in an emergency. And of course, we hope that very soon the National Health Insurance Agency can rise up to its mandate and make sure that every Nigerian is able to access emergency cardiac care and even basic cardiac care in terms of medications without having to bring out money from their pocket. This would dramatically change life expectancy in Nigeria. We can actually live very long if we put our hands together, eat well, exercise well, see our doctors on time, have good checkups, and have access to the best facilities that are available in Nigeria.
Dr. Seko, thank you very much. Now let me get back to the studio here where we have Professor Odele. Now, we're talking pretty much about availability of treatment, technology, and the likes of it. How can we make it more accessible? And I'm talking about heart treatment, heart health, whether it is preventive or curative. How do we make it more accessible, more available, and cheaper for the ordinary people?
Thank you very much for asking this question and really bringing up this discussion. I must thank NTA for, collaborating with us to bring out this discussion to the entire country. Nigerian treatment of managing heart disease, let me use it that way, is a very expensive thing. Expensive in terms of cost, in terms of machine, in terms of the different manpower that you need. It's not just the cardiologist, you need the cardiac surgeon, you need the perfusionist, you need cardiac nurses, you need perfusionists. Of course, you need those who are experts in preventive medicine. So you see...
Do we have this manpower in the country?
Yes. But what happens...
We still do?
Yes, we do. Despite the Japa syndrome, I'm going to give you the picture. Now, some people listening to us now may think, this heart disease is so much, so what I'm going to do is just to invest and build a cardiac center. That is not usually the issue. What we are advocating now is to have a collaborative approach, because this training, we need to extend this training. For example, all over the country, as at the last time I did a bit of an assessment, we have only 4 perfusionists. So you'll be surprised that there is a cardiac surgery happening in Ife. For example, one of our colleagues is in Ife. It's the same perfusionist that does that will also go to Lagos. Our colleagues in Lasut are also doing a lot. So you discover that this manpower is the one that moves around to carry out this surgery. So it's not that it is so exceptional, but because you see the cases are not frequent. So you see, a government or an individual may say, we want to invest into comprehensive cardiac care. He puts the machine, then because of the fact that it's expensive, many people cannot afford it, and if you don't have enough cases coming to that center, then the manpower will not get adequate number of cases to enable them perfect their skills. Sometimes some people may think, what we can do is send people outside the country. Yes, a lot of members of our society have been sent out, gathered skills, and they are back. Some people may think what we need to do is to import experts from abroad. But what we are, advocating now is that we can develop a collaborative, comprehensive cardiac care. We are already discussing that, and we're going to start off with Abuja as a model, whereby, we pool resources together, people who have expertise in doing interventional cardiology, people who have expertise in non-invasive diagnostics, expertise in open heart surgery, then the perfusionist. You know, we bring people who are in training from different parts of the country. This is something that we believe will take us the next 2 years. We all meet here, pull these cases together, talk to the companies that manufacture the consumables that actually make these things expensive, so that the costs will come down. By the time we do this over 2 to 3 years, we will be able to develop critical manpower that can now go at different parts of the country and continue the process. But if we start with investing in building very, expensive, bringing in very expensive machines without having, organized setup for having the expertise that will manage. There are places in this country that have established equipment-wise, let me not call it established cardiac center, but established equipped unit, but it's under lock and key. In this country. So those people need to come out. We can help. That's why we know what is happening in the whole country. We can put these resources together, develop the manpower of people from all around the country, and then this can now go on subsequently.
Anyways, maybe I should call you a data cardiologist, because so far you have been giving us data on this. Give us the data as regards the successes of the surgeries that have taken place in the country so far.
This is a very important. I will refer you to the website. In fact, our colleague in Lagos, developed a website. Maybe Fasan may help me to get the website so that we can even put it for all Nigerians to see. That website, you can see the centers in this country where cardiac surgery, for example, is going on. Remember I said care of the heart, there are many, many things. It's not just cardiac surgery. You have interventions. You have preventive cardiology. Of course, that's where I have my strength. So when I talk about prevention, because if we start from prevention, then the other end.
The website is.
Okay, so maybe Fasan will help us get the website, so that
But give us the data.
The Nigerians will be able to. But there are in this country at the moment, open cardiac surgeries are going on in Obafemi Awolowo Teaching Hospital in Ile-Ife. There is open heart surgery going on in Federal Medical Center in Abuja here. Open heart surgery going on in Lasut. Open heart surgery going on in UNTH, Enugu. These are the ones I can easily, but if you go to this website, which we are going to show, we are going to see places where this is happening. Then for interventional cardiology, of course, the Dr. Iseko Center, that's the cardio care here in Abuja. NNPC Medical Services here also in Abuja has got, in fact, from this place I'm going to see the MD of NNPC Medical Services, because we are thinking of, developing an Abuja model of what I call collaborative, comprehensive cardiac care. That will be an Abuja model sold to the whole country. I'm going to see the MD of NNPC now.
Yeah, beautiful. I still want more data.
Okay.
The data I'm asking for now is the surgeries that have taken place in the country.
Okay.
How successful have they been?
Oh.
How long, when someone, undergoes a surgery in the country,
Okay.
As regards the heart, how long do they live afterwards? How has it been?
Okay, this is what you want.
Yes.
Excellent. The cardiac surgeries that have gone on in this country have been successful. I mean, I wish Dr. Alioke, the cardiothoracic surgeon in FMC Abuja, is here, so that he will give, maybe what we'll do is that we can bring cases that are done in the country. We'll bring them here in the studio. Maybe that can help.
No, but
us.
do we have an idea? Do we have an idea? Because,
Okay.
for instance, the day we talked about kidney here, we talked about transplant.
Okay.
And then somebody said, look, that all you can really do after a transplant is manage. Because I've seen people, I know many people who have ultimately passed, not at the time that, not ripe, when they passed after kidney transplant. So is it the same for the heart? Do they get to live to the fullest?
I understand. You see, there are, here and now, we talked about different diseases of the heart. Let's say that somebody has simple VSD, what we call VSD, ventricular septal defect, a simple hole in the heart, and it was caught early, the complications hadn't set in, and you close that VSD. For all you care, the person will have his or her normal life. But you see, if you wait and that VSD has affected the heart, the myocardium, and you now want to correct, you may correct, and maybe that reduces the person's lifespan, because some damage, necessitated by the complication had taken place. We've had people in this country who have had, what do you call it? Interventions. That's the one that Dr. Seko was talking about, and you put a stent. For the past 5-10 years, and they are still alive, they move around. We've had people who have some open heart surgeries, even here, either in last week. So they are there, and they live. So, the point I'm making is that I will not tell you here that this is the age. It depends on the disease. It depends at the time it was. The intervention was done.
Okay, thank you very much, Professor Odili. Because of time, let's quickly get to Dr. Fason now. We've talked about the surgeries. At what point is transplant necessary? And then where are we in the country in terms of heart transplant? And then is there a role alternative medicine can play in dealing with heart diseases?
Okay, thanks again. I'll just touch a little on what Professor Odili mentioned. I would say that just to add to what he said, the success rate in Nigeria is comparable to international rates, because heart surgery in Nigeria is in different forms. We have local expertise. We also have a large number of Nigerians abroad coming in to come and operate here. One of them is Nzewi, Dr. Nzewi, who is in Ireland. And then this Nigerian Heart Foundation, there are Nigerians in America who
Cardiovascular Foundation.
Nigerian Cardiovascular Foundation, they come to Nigeria. They've been doing that for the past 8 years or there, about 10 years now. And they come every year. They collaborate with Nigerian Cardiac Society and other centers. So a lot. So the rate is comparable. But like he tried to explain, it depends on when you catch the patient. If a child has a hole in the heart and you fix it at that time, that hole has not had untoward effects on that heart. That child will grow to, will have a normal lifespan. If that same child, by virtue of no diagnosis, poor knowledge, no money, even if the diagnosis was made, and the child continues to struggle to the age of 10 or something, by that time, that hole, which was not an issue really at the beginning, will have caused the heart to dilate, enlarge, fail. Even if you fix that hole at that age, that heart is a problem still. So those are some of the things that modify success. Not in Nigeria alone, everywhere in the world. However, peculiarly in Nigeria, because diagnosis might not be made early, even if it's made, funds might not be available for treatment. And so in all these things we are saying, really, it still goes to the government. He is the president of the Nigerian Cardiac Society. He's saying a lot of what the NCS is doing that Nigerians don't even know. But you know that one government policy, just one government policy, right one, would change the story in one day.
But has the society met with the current Minister of Health and, to make this known?
All these are an ongoing process. All these discussions and all that are ongoing. The data that he keeps talking about, you cannot do anything without data. He just talked about a website, which I've given you, www.nigerianheartsurgery.com. Any Nigerian can go on that platform. You will see the centers doing heart surgeries in Nigeria. You will see the numbers they do. You will see everything there, the types of surgery they do. And this opens it up to the space.
So what about alternative medicine? Are we looking that way?
So when you talk about alternative medicine, I ask the question, what do you mean really?
In 30 seconds, please, because we're
Because
out.
when you say alternative medicine, nobody practices medicine anywhere in the world without evidence. And no doctor is against alternative medicine. I think we need to drive that home. What we talk about is provide the evidence. If you have evidence that something that your grandfather does works, and I can tell you that not most anyway, but a lot of the drugs that we use today in orthodox medicine, they initially came out of roots, herbs, leaves, and all that. But over time, we then had evidence that these things work, and we've tried it in standardized settings, and we know what possible side effects, we know the molecule.
All right, so it means that we're not looking at homegrown solutions in dealing with heart diseases, right?
No, you can't say that. We shouldn't say that. That does not translate to alternative, the initial.
All right, because of time. I think we'll take that to another conversation. But let's quickly get to Dr. Iseko now. Your final thoughts as we round up the conversation.
30 seconds, baby.
My final thoughts are that, people should go get their selves checked. When you don't get yourself checked, it's occurring to doing self-harm. Get yourself checked whenever you have any problems. And when you have a problem, go to a doctor, go to a cardiologist, and try and make sure that you get good care. And when care is given, that you stick to the care over time. Now, when and if any surgeries or interventions are needed, they are available in Nigeria, even they may be expensive. We call on the government to do more in terms of insurance and making sure that the citizens are well covered so that they can be able to get access to the highest level of care at all times, especially in an emergency, so that they do not have to suffer deleterious effects of bad health.
Thank you very much. Professor Hadiza Seidu, in 30 seconds, your final thoughts. We're out of time, actually.
Okay, finally, the key to cardiac diseases is actually prevention. Health promotion is the key, and then, of course, advocacies to government agencies and then to individuals as per the magnitude of heart diseases, how to identify them early, how to prevent them, and how to get intervention early. Thank you.
Professor Hadiza Seidu, consultant cardiologist, Northwest coordinator, Nigerian Cardiac Society. Thank you so much for joining us for the conversation. Dr. Iseko, consultant physician, interventional cardiologist, Cardio Care Multi-Specialty Hospital, Abuja, and Group Medical Director, the Limi Hospitals, Abuja, and Chairman Guild of Medical Directors, FCT chapter. Thank you so much for joining us for the conversation. We do sincerely appreciate you. Of course, Professor Augustine Odili, President, Nigerian Cardiac Society. It was a pleasure to have you for the conversation. And Dr. Oladipo Ofason, Senior Consultant Cardiologist, Head Cardiology Unit, National Hospital, Abuja, and also Secretary General of the Nigerian Hypertension Society. Thank you so much. Of course, looking forward to more engagement on this particular topic. So that's Good Morning Nigeria this Friday. Take care of your heart. Avoid heartbreaks. I'm Ian Ray John.
All right, and I'm Victor Azu. Take care of your heart, and it will return the favor with a lifetime of bits. Have a great weekend.